Well, greetings everyone. I am in Arizona right now, Phoenix, Arizona, and it's 10, 10 o'clock, 10 p.m. right now here. And good morning to everyone in India, and good evening, late evening to everyone in US and elsewhere. Well, first of all, I kind of was talking with Surabhi about what would be the thing to present here. So I hope if microphone, that would be really, really helpful. Well, I have prepared some things that would be interesting for both the public health community as well as, and I'm getting some flavor from. So before I go further, I want to be very kind gratitude to Dr. Dilip Mavalankar and Dr. Surabhi Pandey and many others who are behind the scenes. And I didn't know about them. So greetings and gratitude to all of you guys for arranging my talk. It's my pleasure to talk to everyone and everyone in the public health community as well as in India and rest of the institute, whoever is joining us. So, well, I want to show you guys a picture from our last meeting in 2018, sorry, where in New Delhi, I met with Dr. Prabhakaran Turikraj. He's also a member of Public Health Foundation of India. And we had quite an interesting conversation and research conversation. So I want to bring it, and Dr. Surabhi Pandey is also seen in this picture. So this brings up back. So my connection with Public Health Foundation of India goes back long, and I hope this connection will keep continuing as well. So, well, it would be fair to actually first talk about what I am as a person, what type of researcher I am. So just to give you an idea, I am originally from Kanpur. I did my undergraduation from college, Christchurch College in Kanpur. It was part of the Kanpur University. But then when I went on to do masters in mathematics at IIT Kanpur, where I have wonderful experience with pure as well as advanced mathematics of different sort. Also was part of, I got a classes with Professor Piyush Chandra, Professor Praval Sinha, and many others who are very well known in the modeling world. Then I went on to do an applied mathematics PhD program at Arizona State University. There, it was more applied than what I have seen, what I saw in IIT Kanpur. And I got a hands-on experience to work with empirical side of the world. And that was really interesting projects, different projects that I worked upon. Then I got a postdoctoral position after that at Cleveland Clinic, which is the second largest hospital in US after Mayo Clinic. I was working for Department of Infectious Diseases, and I was part of clinical trials for HIV, where they were trying to understand the role of drug resistance for pre-exposure prophylaxis. And then I was part of a Center for Global Health at Case Western Reserve University, which is also in Cleveland. There I worked in lymphatic filariasis in Papua New Guinea, and I was also part of a clinical trial for mass drug administration. So, I mean, if you see my background, it is going from a hardcore theoretical analysis to all the way to very applied and part of a clinical trials. And now I'm part of a group which is called Precision Here, where we talk about health economics and policy. So my background is varied, so I understand a lot about how the mathematician thinks versus how the infectious disease person thinks versus the global health person thinks. And I have been very lucky in this type of experience. So with that, let me talk about what I have to talk today. But before I go further, there's a disclaimer here. I'm not an epidemiologist, even though I have a good experience. I'm not an epidemiologist. I'm not a clinical expert. I'm a mathematical modeler by training as well as by my thinking, and have been working on different types of infectious disease and its control. So today's outline, actually, I thought over it, what would be the best thing to do it, because being mathematicians from a heart, but also I've worked on very beautiful applications and infectious diseases. So I kind of thought from a COVID-19 as a current outbreak. So many of these things are related to COVID-19, but also there are some things that I'm bringing from my own background, which I have done in past decade or so. So first I will start with an historical outbreak. I will talk about how changing trends in epidemiological knowledge has helped or not helped a COVID outbreak. What are the scenarios, current scenarios in developed and developing world? India is a developing world, whereas the US is a developed world. Um, and uh, um, and then I will talk about three different projects that would be. Um, can you guys all mute a microphone, please? Thank you. So I will talk about three different projects on underreporting, preparedness, and silent typhoid Marys. And I think underreporting is very clear word. Preparedness is also clear. Preparedness from a health perspective, public health perspective. And silent typhoid Mary is what I'm using it a term for asymptomatic hidden infections that are very common in COVID outbreak. And then I will talk about some of the modeling predictions, what are the limitations and challenges through modeling from the modeling perspective. So with that, let's hear something about what is special about this COVID-19. So it is unfair to talk about COVID-19 and we do not talk about something that we already know about from the historical facts. For example, in 1918, Spanish flu, we did not know I mean, actually, it was believed that it was a bacterial disease that is spreading in that. But it was not until 1933 that was known that influenza is spread in humans through a virus. So it was 1933 that we came to know about it. So it was after 1918 influenza. One of the specialty in 1918 Spanish flu, was a city named Philadelphia and St. Louis in the US. And they had a very different outbreaks curve. And if you see on the right, one outbreak, the yellow one is of Philadelphia, and the one which is bottom blue, light blue, is a St. Louis one. And you guys might be hearing a lot in the news about flattening the curve. It was in Philadelphia. Once the first case was identified, it took 2 weeks to implement the social distancing policy. And you see and whereas the St. Louis, it was within 2 days of the first infection, they implemented and that resulted in quite a drastic change in an outbreak, for example, curve. Now, what is the difference? Of course, it looks like that it is shifted, right? And it has flattened it a little bit. But it also, in St. Louis, you can see that it is elongated. The outbreak is elongated. So what is the benefit of using the social distancing? And the one left bottom corner of my slide, you can see a few things that helps in flattening the curve. One is that if you see a dotted line, that is healthcare system, how much they can handle in the healthcare, because hospitals have limited bed, hospitals have limited doctors, limited resources. So if there are more than So one thing is, if you do social distance, if you do not know anything about an outbreak and it's a new outbreak, the best method is the social distancing. That means reducing the contacts, average contacts by like staying at home, for example. So in that case, the curve goes down, but then it gets shifted to the right. What is the benefit? Benefit is, of course, you are under that dotted line. So all your healthcare facilities can handle any extreme cases that are happening. The peak is down. But not only that, the area under the curve is also less. Area under the curve means total number of cases would be less as well. So these are the two primary reason why we kind of push forward for a social distancing thing. When you don't know anything, when there's no treatment about it, and you don't know much about the infection. So this is very, very important and very important historical facts that we work upon it again and again in an outbreak. But having said that, we are, even though we are surprised by COVID-19, but this is influenza or flu strains have been circulating in human population for quite a long time, and many people died. It may not become a pandemic in many times. So this is a timeline of some of the deaths and some of the outbreaks that has occurred. The recent one was a swine flu, which was in 2009. No, sorry, it was in 2009, yeah. And it was H1N1 influenza, which caused 15,000 deaths. But there has been many other, like Hong Kong flu in 1968, that caused 700,000 deaths. 1957 avian flu that caused 100,000. It may not have spread for the whole world, but it has been, these outbreak has been in the human community off and on, basically. And so it should not be a surprise. The surprise comes from the fact that it is now COVID-19 is everywhere in all the almost all the countries, and it has been spreading fast. And we don't have the treatment for it, or we don't have a vaccinations for it. So this is just to give you a perspective on the background. But let's hear about COVID-19 and timeline of it. Well, we all are hearing these news about COVID from January onwards. In fact, December, even early December also, we heard many news on that. And I have noted down a few of the important aspects in this timeline, but there is a specific reason why I am kind of identifying a color coding here. And the color coding is kind of helping people to model. It was whatever the model we are using currently for COVID-19, it is not the same model that we used in February or in March or in April. There is an evolution of models over time span. And these color coding is a significant evolution of the models. For example, we didn't have much information until February. We know there is an outbreak, but how is it spreading, whether there is asymptomatic, whether it is other things or not, we didn't know. So model was very simple early on, the simple epidemic models that we were modeling until February. And then the orange part, which is right about in the March, we started to get to know incidents of Diamond Princess cruise ship that resulted in many, many infections in the cruise ship. And it was then we realized that it was a super spreading events that might be causing some of these things. Close contacts might be a very important aspect of. So the model quickly shift from a simple epidemic model to something where they started to consider more contacts in that. And then basically, there was news about, okay, how do you control it? The WHO say, well, the best thing is social distancing. So everyone started to build something on the social distancing, in fact. So the model now is started to focus on social distancing rather than epidemic spread, simple epidemic spread. So, and then basically, later on, we found New York had a high number of deaths. And everyone was surprised. Why is the New York, as one of the best city in the world with so many resources, having so many cases, so many mortalities there? So then the question starts to come, what are the characteristics of the population that is causing this thing to have a high mortality? Well, in New York, one of the reasons was socioeconomic factors, as well as the density of the population that causes the high mortality. But again, in India, there is lots of places which has a high density. Why is the mortality not having? So we don't have a clear answer, but the model started to switch from social distancing to looking at the mortality data now and seeing if we can identify the explanation of differences in the mortality in New York versus other cities, for examples. And then basically, finally, now we are talking about disease are spreading in the developing world, in India, in African country, in South America, it is spreading like havoc in Ecuador, in Peru, in Chile. They are spreading like crazy, and there are lots of mortality happening. So the question is, what do you do when the resources, these countries do not have good manpower, good resources? The models now are shifting to the resource limiting constraints. And how do you model when the resources are limited? So, I mean, the timeline everyone knows, but we do not realize the fact that the modeling has also evolved over a period of time into what to focus on and what do we put in the models and what informations are available. So, well, there is one of the difference quite significantly that we are observing nowadays is between high income and developing countries. You saw early on, China was where the virus was originated from, but then quickly Europe was the main target, but then of the virus, and then Western world, US was then the target. Developing world didn't got that much of impact, at least in the starting. But now we started to see these changes. Can we answer why is that happening? These are the things that we need to understand and we need to model. What is causing? What is the mechanism of the system or the pathogens that are driving these systems? Not at the early stage in the developing country, but now, for example, in that. So these are the now in India, it is spreading. In South America, it is spreading quite drastically. Even some African countries are also seeing. Now, some of the developing country, we are not hearing there is an outbreak. That doesn't mean that the outbreaks are not going on. It is just that the testing is not very good there, for examples. So, well, as of now, as of April 30, low or middle income countries, which has 80% of the population, has only contributed to 14% of the total death, reported death. Let me say, it is a reported death. That means there are lots of unreported death that we don't know about actually. Now, there are some limitations that we can model. For example, hospital beds are very limited. Per 10,000 people. There is a very good statistics by WHO, which is updated every few years online, that says how many beds are available per 10,000 people. For example, Bangladesh has 8 beds per 10,000 people, and US has 24. European Union has 64, for example. So those things, resource limitations are very, very important nowadays to model in the model. And we are not, some of the mathematical models that are coming right now without taking into account those those resource limitations, which is the limitations of the models. Another aspects is we are looking at the outbreak in isolations. We are not looking this outbreak jointly with other factors that are making a huge impact. You cannot look at the epidemic, for example, in US, simultaneously an opioid crisis is going on. Opioid is painkiller. People are misusing painkiller, and it was going on before the COVID-19, but now it has aggravated because of COVID-19. And for example, homelessness is an outbreak going on California, Los Angeles area, for example. So, I mean, it has become humongous problem, and some of these populations are vulnerable because they have pre-health conditions, and that is causing this. So if we understand COVID-19 in isolations or model it in isolation, that may not be a fair deal. We may have to think about local characteristics that might need in the modeling world, for example. So let me give some outline. Some of you might not have had a prior background on modeling of an outbreak. So I will give us some brief outline of how do we model, how do we think in the models, and then I will give some examples from my research to talk about. So one of the two basic questions when there is an outbreak, the two basic questions that we ask is how contagious is the pathogen? That's the one of the basic question comes to the mind. Any outbreak that comes in the population. And the second one is how virulent or how dangerous is the disease. Dangerous means how many they are killing, basically. So how contagious is modeled basically by something called as a reproduction number in modeling world. And reproduction number is basically how many one infected person is generating secondary cases, how many new cases a person is generating. And that, if you measure that thing, if you can find out those numbers, basic reproduction numbers, then you can tell how contagious is the pathogen, how contagious is this new virus. So that's a very important disease, and it has primarily three components. It has during an infectious period, that means a person who's infected during its infectious period, how many total cases he or she is generating. What is the contact structure of the population? How often people mix with it? For example, in Delhi, the density of the people is much higher than if you talk about I don't know. I mean, maybe a village in UP, for example. So there is a huge difference in the density, and the contact structure is very different. So reproduction number takes into account that contact structure, and then probability of transmission in a contact, which is a nature of a pathogen to how fast it spreads. Now, also on top of it, which defines the contagious in the pathogens, is the population behavior. Because we all hear news, we all hear, we talk to each other, and we get to know various aspects of an outbreak. And so, well, we change our behavior based on it. For example, if there right now there is a lot of cases being reported from Arizona. I'm in Arizona, state of Arizona. And so instead of going every week to the grocery store, now I'm going every 2 weeks to the grocery store. So I've changed my behavior based on the media information. So population behavior is continuously changing based on many, many factors. And that needs to be considered into account also in terms of how contagious is the pathogen. Second aspect that I was saying is the basic question is how virulent or dangerous is the disease is measured by something called as case fatality rate, or it is also measured by mortality rate in general. Now there is a case fatality rate is basically number of people who have died divided by number of total cases. Now the problem here is that in order to calculate this fraction, number of died divided by number of cases, you have to know number of cases. Now, number of cases you will never able to know precisely. Why? There are many reasons. There are lots of people who are asymptomatic. There's lots of people who are symptomatic but are having mild symptoms. Number of people who are going and reporting themselves to the private hospitals who are not reporting the COVID cases, for example, or they don't have a good diagnostic test, or the test is failing. There are multiple reasons why the number of cases may not know. I mean, precisely know. So this rate is kind of vulnerable to how you measure things. So without thinking these aspects of measurement in the field, it is very difficult to model accurately whatever the question is there in your mind. So in this table, I'm showing some of these diseases and their reproduction number and the case fatality ratio. For example, measles has 50% case, where 50% of the infected cases die out of all the cases in the measles, whereas common cold, it is only 0.1%, which is very low. Okay. Now, one thing is is important here is the route of transmission. What are the pathogen look like? Is it spread by body fluids? It is spread by droplets? It is aerosol. Aerosol is something by which can travel in air for long distance if we cough, or these particles of the pathogens can travel quite long distance. And droplets are a little heavier and these have a weights associated to it. So if I cough in COVID-19, it may not go that far as compared to measles, for example. So because they are heavier droplets. So these are very important in transmission process. And I said the contact is very important. Contact, how do you define contact basically? Contact is not just by touching someone. Contact could be standing in a distance of someone for a certain amount of time. So these are the technicality that goes in the modeling equations that makes it very difficult to model it accurately, or not difficult, but challenging, I would say, to model in the world. Anyway, so one of the things that has been reported in the literature is reproduction number. Well, reproduction number is average number of secondary cases generated by one infected person. How many new cases this person is generating? Okay, now we sometimes use this thing kind of some of the articles I've seen incorrectly, but not all of them, some of them do. Well, they use basic reproduction number and effective reproduction number interchangeably, for example. Whereas there is a significant difference in what reproduction number you are talking about. How did you measure it? And you cannot use these one interchangeably with others because the meaning of it is very, very different. For example, basic reproduction number is used at the starting of an outbreak. When the outbreak has very few cases, then only you can use a basic reproduction number. But then effective reproduction number, you can use it over time. And the computation of that is very different also. So we have to be careful of what we are talking about and what is the literature saying. So just wanted to specify these things because we hear these news, read these news again and again in the newspapers. One thing I want to show is this is a very simple idea, but it could get complicated very quickly. Just to give you an example, suppose there is an outbreak. So in Washington state here in US, there was an outbreak very starting early on. And before New York, it was a Washington state that was basically a big problem. And what was happening is there the disease was spreading between community and long-term care facility. Long-term care facilities are the facilities that have old people or people who cannot walk or are disabled in some sense. So old people are more vulnerable. So for example, if the reproduction number for community to community, the people who are infecting in the community is 0.8, and one in the long-term care facility in 0.7, which is both are, so one person, 0.8 means one person is infecting, one person in community is infecting 0.8 people. What is 0.8 people? Less than him. Some people will infect, some will not infect at all. So on an average, 0.8 infected people, one person will infect in the community. So, and same thing in long-term care facility, it is 0.7. And between one person in long-term care facility in the community will infect 0.4 because they are moving, they are going around everywhere. And same thing. So these all reproduction numbers are less than 1. These are reproduction numbers. So average number of new cases they are generating is less than 1. They have to infect more than 1 in order for a big outbreak, because otherwise they will not replace him or herself as an infection, new infection. So each of these numbers are less than 1, but if you talk about a population as everything, then the whole population has a reproduction number of 1.1. That is greater than 1, basically. How do we calculate that thing? So let's see an example. So suppose there are 100 infected people in long-term care facility. Suppose there is just single long-term care facility. And there is a community people, there are 1,000 infected people in the community, right? And so with this reproduction number, 100 people in the long-term care facilities infecting 0.7, Each one is doing 0.7. So 100 infected people were there. So then the second generation, there will be 70 new people, right? 70 new people, because 0.7 times 100 is 70. And then 0.2 is in the community. CY stands for community and LF stands for long-term care facility. In CY community, these long-term care 100 people will generate only 20 infection because the reproduction number is 0.2. And so on. In the community, the same way you can calculate out of 1,000 new cases will be generated 800 and 400 respectively. So how many total cases are there? So now initially I had 1,100 people, and now new cases are generated around 1,290. If you sum all these ones, it will be 1,290 total people. Okay. So what is the reproduction ratio? Reproduction ratio is average number of cases one person will generate. So if I divide 1,290 by total new cases were 1,100, and each one generated, all of them generated 1,290. So per person cases generated is 1.1, which is bigger than 1. So even though each reproduction number is less than 1 in each of these table, the population reproduction number could be greater than 1, and therefore there will be an outbreak in the community. Very good example to show how complicated it can become based on what you are modeling, basically. So we have to be careful what the question is and what are we modeling. Now, as a task of a mathematical modeler, we do many things. We do modeling. That means understanding the disease and disease aspects and writing down the equation. For us, the model is equation. For biologists, the model is mouse. And for social scientists, the model is flowchart. As a mathematician, the model is equations, some sort of equations. So writing down the equation from understanding a biological or epidemiological information is what is a big deal. It's a big deal because reality is very complex and you are writing down into very simple equations. So that is our task. But then also linking these models to the data. Now, these model needs data to predict something or to do something. So there, the statistical analysis is very critical. And then, of course, policy implementations of how the interventions will work. For example, in India, they did social distancing very early on, which was a very good thing. But did it work? Well, partly it worked, partly did not. Why? Because the migrant started to move by themselves. They started to. So policy, even though from the mathematical modeling perspective, which was saying stop social distance, stop everyone's movement, but the policy implementations is a different angle. And you need to think from those ends what needs to change in the model to make sense out of it. And many model fails to do it because they were not taking into account change in human behavior due to these migrant movements, for example, in India. So anyway, we have different questions at different points. How fast the epidemic is growing. As a mathematician, we ask what will be the peak of an epidemic? When should we implement certain types of control? And if we implement it, how fast it will decrease, and so on and so forth. There are different questions we can ask as a modeler. So as a modeler, what we model is like a bucket full of water, whereas something coming in and something going on out of the bucket. And we are interested in knowing what is the level of the population in it, or the level of number of infected people in this bucket, for example. So we model it as a box model. So we think about population as a train. You know, there was a movie called as Ashirwad, very old movie, which was by Ashok Kumar, and it was having a train in it, and there was it's basically it's a chain of things. We are dividing the population into compartments. One we are calling at susceptible people who are not really infected. I is who are infected, and R is who are recovered. So we just divide it, and then the question is, how do you define transmission and recovery from the population? And there are certain parameters that goes into it. I have to rush here because the time is limited, I think. Well, in number of infectious, if you simulate it, you write down these differential equation using a bucket idea. So something is coming in and something is going out in the eye compartment, and you can plot this thing, and you will have this type of picture showing an outbreak peak. Now, there is something which we are saying, there won't be an outbreak every time, only sometime there will be outbreak. There will be outbreak only when the number coming in has to be greater than what is going out the bucket. Okay, so a number coming in is beta, which is coming in, and number going out is gamma, sorry. And the ratio of that decides whether there will be an outbreak. So if more coming in and less going out, then there is an outbreak. If less coming in and more going out, then there is no outbreak. There is no peak. Well, not only this, this value of an R naught helps in understanding basically the higher the value of this, the higher the peak is and early the peak is. So R naught is 10, the peak is quickly and higher. And if R naught is less, then the peak is later on, basically. So this is a very simple idea of R naught that we talk about. Well, we can make this model very complex based on an idea. For example, the second model, SIRS, is what we are thinking about modeling now. Why? Because there has been news that saying that we may not be getting immunity, permanent immunity from the COVID-19, for example. So some people are going back from the recovered compartment to a susceptible compartment. So second graph would be more better in that case. So anyway, so there is a treatment model, there is formite models. For example, you want to talk about environment. The X is the right, bottom right is an environment. How is the environment is infecting? For example, in the hospital setting, the doorknobs or anything like desk, table where the infected person has touched may cause the infection. So in cholera, we model something like that, for example. So let me go to my research very quickly because I think the time is limited, and I will talk about underreporting. Well, there is something called as excess mortality data. We don't know how many people are dying, but in Jakarta Department of Parks and Cemeteries, they have disclosed how many people have buried in the past few months. And usually they compare it with the last year and find out how many excess deaths are happening this year. And so what it is saying is the 12% of the deaths are not being reported to it. So there is high underreporting that is happening, and this burial data is being used to find out how many truly cases die from COVID-19 versus last year, for example. Okay. Well, underreporting occurs due to testing, due to super spreading events, due to time lag, reporting time lag, due to policy also, because if you are symptomatic people, you are only kind of identifying. There could be policy issues also, seasonality issues, sensitivity and specificity of the test get cause also the underreporting in that.
Yeah. Dr. Anuj, you can take more time. I think we have 1.5 to 2 hours, so don't rush through because it's quite interesting. Well, we may have to restrict the question answer time. Sure. And maybe send you the questions later on.
Sure. Thank you for letting me know, because I think I had a few more slides. So yeah. Okay. So why under
বললো যে ডক্টর অনুজ প্লিজ
Yeah, I'm hearing. Hello. Okay. So so I was saying that underreporting, why underreporting, and each of these points we can model. The reason I'm mentioning that thing, we can use each one of the question, these bullet point, to write down the equations and study some of those aspects of it. The goal has to be very clear of the model. Otherwise, we cannot have a very good understanding about an outbreak or the research question in hand, for examples. So anyway, so let's go further. And the definitions are very, very important as well. I mean, we as a mathematician sometimes kind of use these definition in a very less stricter terms. For example, underassertment, underreporting, underestimation is a very well-defined empirical definitions in the literature. And just to give you an idea, for example, underassertment, it means that you are only talking about both symptomatic and asymptomatic cases. So sometimes, basically, clinical symptomatic cases get reported. Asymptomatic cases are never get reported. So understatement is basically a function of how many asymptomatic are there. Okay. Underreporting, on the other hand, is how many cases are getting reported in the public health sector, the surveillance systems of the government. So those we are not really, because many times the tests are not very good. Many times the diagnostic method is not good. Many times someone makes a mistake in writing down as a case. Many times people are going in the private sectors and therefore not getting reported, for example. So even though they are clinical symptomatic, but they are not getting reported. So there is something called as underreporting in that case. The people who are symptomatic, but they are not getting reported. And then if you take both of those things together, underassertment and underreporting, then we call something called as underestimation. These are technical definitions, and we model these things in a very different way. So let me give you an example. So this is a model that we were talking about, simple SIR models, but here I have susceptible. A stands for asymptomatic. I stands for infected, clinical symptomatic. G stands for patients who are correctly diagnosed and treated in a healthcare facilities. And T stands for people who are not accessing reporting agencies or incorrectly diagnosis, but they are going through some path of recovery or the treatment, for example. So G and T are some kind of an hospital setting, but it could have misinformation. T is kind of a misinformation in some sense. So we can model this thing as a fraction of underassertment. We can model as a Q fractions, and we can estimate using these models. Whereas same thing we can do it for underreporting, which is P. Little p is an underreporting here. The clinical symptomatic are not getting reported, and they are going through the T path. So now, what is my data? What is the data that we use in order to estimate what is understatement and what is underreporting? The data that we use is something called as incidence. And incidence is you see the reported incidence I'm pointing on the top right. That is the data we use over time to estimate indirectly what is my P and what is my Q. And that helps us in guiding what would be our levels of underreportation or underassertments. And these things are very, very critical, especially the disease like COVID, when we have no idea about how many cases are happening asymptomatically, for example. So I have this paper that long time ago, it's actually 2010, long time, but it actually takes into account leishmaniasis, which is a kala azar in India. It's a very highly, it used to cause a lot of mortality in Bihar and West Bengal and UP and some other states in India. But primarily, we looked at Bihar, and we worked with Rajan Memorial Institute of Medical Sciences, which is an ICMR institute. And we kind of underreported, we estimated how many underreporting are happening, how many people here, the underreporting was happening because you have to go for a treatment for this disease, otherwise you die. The underreporting was happening because people were going to the private sectors, and private sectors were not obliged to report those cases. And therefore, there was a huge underreporting that was happening. And so we estimated in 2003, it was 88% underreporting to 2005. It has decreased in 2005 due to something they did in 2004. Actually, WHO and TDR, Tropical Disease Research, did some significant things in 2004. So there was a decrease, but we did it for each of the district in Bihar, and basically we tried to understand a spatial underreporting level of the Bihar in that time. So this is a beautiful picture, and we can do the same thing for the COVID-19, for example, in India. Now, the second study is about this one study that it's in review right now. And we have done, I worked with Ministry of Health in Colombia. Colombia is a country in South America. And there is a city called as Cali, which was seeing the very high rise in number. And the question was, they have limited resources, they have no preparedness, they are a developing country, and they wanted our help. So there wasn't any grant for this thing, but we, group of researchers, get together and actually work on this aspect. So this was by public health person from Jorge Rojas. He is in Cali, Colombia. Also, Professor Marlio Paredes. He's in University of Valle, Cali. Dr. Mele Banerjee, he's in Indian Institute of Technology, Kanpur, Mathematics Department. O.J. Ekman, he's also in US, Illinois State University. So the goal here was, what can we do? Now, people think that math model is a magic, but it is not a magic. So the problem came to us, but we don't have a data. We don't have a good data. Reporting system is not very good there. The data is very weak to really take into account. So what do? Usually what people do is they pick up one model from the basket of the models that has been done in the literature, and that's just a model. But instead, what we did was something different. We took many different models. Now, I don't know if you guys are aware of something called as climate models. Climate models are models not by a single models. There's a collection of models. There's called ensembles of models, and they model each many models, and then they average out the result of all the models and predict for some period of time. Now, note, they have been using this thing for a long time. The temperature, rainfall data is very well recovered from the field. So data is not a limitation. And they, in spite of that, they use many assemble of models. They have used many models to predict the climate. But in COVID, we expect to model it using a single model, which is unfair. To my understanding, which is unfair. So we need to do these ensemble of models and average out our results if he truly wants to do a prediction of some sort for somewhere. So we did an ensemble of models here. Now, one more thing in climate model is that they never ever predict good for more than 7 days. Prediction is only for 7 days. Beyond that point, their models fails to deliver. And we were expecting, there was an initial models from UK, from US, from Europe, and many other places. They were predicting lots of cases and a lot of things. And we were expecting these models to produce to the point information about what will happen in a month of time, which is unfair, basically, to my understanding. So there are some limitations of these models. We cannot do those things. So I think we did in this study, basically we use ensemble of models and kind of compare and contrast what will happen if you take this in the model or if you take that thing in the model, and we average out the results in some sense. And we actually kind of gave them some ballpark results. Before that, they were not really aware of anything. They were doing randomly their policies in the city of Cali before this paper. Now they are actually using some of these results, which are an average preparedness results for the city of Cali. For example, if you do only isolation, what cases will be there, and if you do quarantining and isolations for a certain number of days, what will happen, when will be the peak we will going to see, and so on and so forth. There were many results, but just to give you an idea of what we were talking about, interventions we took into account was social distancing intervention, shelter in place intervention, Wuhan style. Wuhan style was the more stricter policy. That means they literally closed down the complete city in Wuhan, basically, in order to go. Whereas social distancing is a voluntary social distancing, and shelter in place is more stricter, basically, social distancing social distancing measure. So these were the interventions and permutation combinations we did, and we. Now, my goal today is not to give you an answer to the solution, rather to give you how we think as a modelers and what do we do as a modeler. So another study that I did with some of my students and some of the people in Ministry of Health in Ecuador, and also some of my collaborators in University of Notre Dame and Precision here. Dr. Edwin Michael is a parasitologist, and he's very well known in the field. I work on many of the vector-borne diseases with him. So here the issue was, how do you evaluate? They were doing the self-quarantine, the social isolation policies, but it was not clear what is the impact it is doing, how many cases it is saving, or how many cases it is, how many mortality we are getting saved. So one of the things which was critical here was the limited healthcare. So they were doing social distancing, but they were not aware of how much impact the social distancing is doing. The models have not taken account into limited healthcare resources in many settings. So we used a limited health code for and spatial distribution of the COVID outbreak and evaluated the impact of it. So now this is more technical, but I just want to show for some mathematical folks the constraint that we are putting. If you see in the top right corner, I have C0. C0 is the limitation of number of beds. So here there are SEAI is the simple epidemic compartment. S stands for susceptible, exposed, asymptomatic, infectious, symptomatic, and R stands for recovered. D is death, H is for hospitalization, and C is ICU. C stands for ICU. Now, what we are building in this is there is a limitation of ICU beds. There's limitations of hospital beds here. And that we are modeling. And we are saying what would be the preparedness when the things are very limited in it. And we are talking about for each of the state there. They call it as a provinces in that in the Ecuador. And this in this picture, you see there's two aspects I want to point you out. One is the horizontal line, which is a hospital capacity. And second thing, I want to point it out that each of these curves are having oscillations, or there is a bulge in it. That means it is showing a second wave of an outbreak, and in fact, third outbreak. And if you go further, there will be much larger, could be a more. But the more further we go, the less precise results we will get, basically. But at least it is showing the two outbreaks, and it is showing how much constraint you should do to the social distancing that you remain within the healthcare capacity, the horizontal line, within the horizontal black line. So that was the simple idea of this work. And I'm not talking about the results, I'm talking about what we model and how we model, basically. Then comes silent typhoid Marys, and just to some of you, if you have not heard about, and this is from Wikipedia information, there was a woman in early 20th century, her name was Mary Mellon. She was later referred as a typhoid Mary. She was a cook, and she infected, while working as a cook, she infected 53 people with a typhoid fever. But nobody knew this thing because she was asymptomatic. And later she was basically isolated, and her last few years was very painful actually. And because at that time there was no ethical board, there was no institutional review board, and so things were not taken that seriously, and she was isolated from the rest of the population and kept in an island country. So very sad situation end of that woman. But one of the important thing there was that while she was infected in a confined space as a cook, she infected customers and fellow co-workers, 53 of them. That resulted in a big deal, and it's a story everyone's in public health and epidemiology know about it. Now, why I'm talking about this? I'm talking about this because we are seeing something similar. What we are referring it as a super spreading events. In Singapore, for example, initially a large conference of a gas company in a Grand Hyatt hotel that lasted for 3 days in January had 109 delegates and infected 7 people. There was one attendee from Wuhan. There was just single one attendee from Wuhan that resulted in 7 new cases, which later on found to be the most, they were the basically spreader for the most disease, basically, in the whole world. They spread the disease in the whole world, basically. They were supposed to, they were thought to be. So seven infected people from that. That conference was very, very important in the COVID outbreak. In South Korea, for example, there was a church where one woman infected around about 60 people while in the church service for 4 hours. Only for 4 hours, she infected 60 people out of 70 people, roughly speaking. In Chicago, there was a birthday party. There was birthday party in 3 hours. 7 new cases were infected, which spread the whole Chicago. There was an outbreak in Chicago that was caused by birthday party. In China, there was a restaurant, for example, that causes 9 people infected in 2 hours during a lunchtime. There was 91 people in there, 83 customers and 8 staff members. This one person who was sitting and infected was asymptomatic, and he infected 14 meters away from his chair. That means there was a role of air conditioning unit that played a very important role. So these are all things are very, very critical in the modeling world, and we kind of very careful when we model these aspects. In Washington State, choir practice resulted in 53 infected people. There was 61 people in that choir practice. So these are beautiful examples that we are thinking about large outbreak in the cities, when these things are literally spreading in a confined places and someone like a typhoid Mary is spreading the disease in some of these areas, for example. So why I'm talking about it, because we are focusing many work on this, but one work I will going to show you today. This work is on airplane work, but before I come to my work, there's Delta recently on April 13th. They changed their boarding policy. Boarding policy is, I don't know if you, in India, I've not traveled in Indian domestic aircraft from long time, but in US, there is a boarding zones. That means zone 1, travel first. Zone 2, travel second. I mean, enter the flights second, and so on and so forth. And the zone system depends on the airlines. Different airlines have different policies. For example, Southwest last year used to have random policy. Whosoever comes first goes first in the aircraft. But in Delta and American Airlines, there was zone system. So in recently, April 13, they changed their thing. They said, okay, we do it back to front randomly. So the back row will go first, will enter the first, and then in the order they will come. The first row will enter in the very end, basically. So and they were not doing it before. They were doing zone wise before. And the second thing what they did was they said they will leave middle seat vacant. So now we are stuck to the modeling. Is this a right policy? Who did the modeling there? Nobody did the modeling. They just decided that this is the policy. So we went on to do with a group of researchers from University of Florida, West Florida, Arizona State, Columbia University, and Embry-Riddle Aeronautical University. And we kind of evaluated these policies of boarding inside the flights. And well, we did not use a typical SIR differential equation type model. There's one thing which is very standard in the mathematical world is I have learned one method and I use that method everywhere. Well, it depends on a research question. That method may not be useful for that method, for that problem. So in that case, we use this study from from physics. There is a pedestrian dynamics models that are very common in physics, physical aspects, and they model in engineering application quite a lot. So we picked up the literature from there and we model behind the scene as a susceptible, infected, recovered model, but we use a different type of, it's called as force field model. That means people are moving and they are getting repelled by vicinity of the other people or the velocity of the other people or some kind of an obstacle, maybe a wall, for example. So, the people change their direction based on this velocity of the other people around them, basically. How do you model those? So we used something like that, which we called as a pedestrian dynamics models. So just to quickly give you an idea, we consider a few zones. So top right, top box, I'm showing 4 different zoning system. One zone. First zone is passenger board in random order, no preference given to the business class passenger. They just go randomly. Sixth zone, business first. That means business class goes first, and the rest of the plane is divided into 6 contiguous zones. That used to be the case before the COVID outbreak, by the way. The 6th zone used to be the case before the COVID outbreak. But we also incorporated in that that zone, within zoning, it is random. Within zone, the people are entering is random. Whosoever come first within the zone will go randomly there. And then back to front, where you are doing what Delta has started to do on April 13th for the COVID outbreak, row-wise boarding with the last row first, and no preference is given to the business class. And then back to front, business first, and you give the preference to the business class first. Now, when we did these things and we used the model, we find a contradictory result. The policy that they did, actually, the Delta Airlines on April 13 was actually one of the worst policy you can do at the time of a COVID outbreak. But they are just doing it for someone in higher up in their organization have decided to do something like that without doing a modeling exercise for it. So anyway, so this was an eye-opener, and our work was very highly advertised, and it is actually under review right now. So this was one of the work that we are also doing a work with in long-term care facility also with a professor from University of Wisconsin-Whitewater, and her name is Aditi Ghosh, and also Dr. Malay Banerjee from Indian Institute of Technology. And that work is still on the paper, and also with a professor from George Mason University. His name is Padmanabhan Fisher. So with those folks, I'm doing that work. I don't have the result yet, but I plan to have it in few days, and we would going to submit for publication. But basically, I want to end here with some note here, is that I discussed today challenges and limitation in the modeling. What are the limitations? How do we model? What are the data limitation? What are the modeling limitation? Where should you focus? One should be questions in hand. We cannot do prediction for 10 months in advance. It is impossible. I mean, as we see in the climate models we are doing, because one of the reason is human behavior is continuously changing. And these policy actions are in policy, government policies are driving this, human behavior. So with that, I would really end here and thank you all of you for listening to me. I had many more slides, but I wanted to give some basic idea about modeling and how the modeling have changed. But still there is a long way to go. But there is, if we feed garbage in, garbage out. So if the data will not be very good, we will not be able to say much about the prediction. So with that, thank you everyone for coming and listening. And of course, Public Health Foundation of India, Gandhinagar, I'm very grateful to them, as well as Public Health Foundation of India in general, all the institutes. Thank you.
Thank you very much, Professor Anuj. I think we open for question and answer. I will ask Anurag Saxena, Professor Anurag Saxena, who is a faculty member at IIPH Gandhinagar, to conduct the question answer session.
Sure.
Yeah. Thank you, sir. So one of the question that we have received is that you said averaging model gives a relevant result. Question is how to optimize the number of models that need to be simulated, and what should be the criteria to choose such models from the basket of models that are available to us.
Well, that is what, very good question, excellent question. And that is what my flavor was for my talk today, was that there's no one size fit all. The models are driven by the question in hand. And that should be guided this thing. What questions we are trying to address for it. So, and what is the availability of the data in that thing? Now, suppose you want to model certain question, but there is no information available, then there's no point we can do so many of those things. So, so it is, there is no one answer to that. It comes by, there's lots of literature on the modeling. There's huge number of work that applied mathematicians have been doing for decades, maybe a century, I would say. And they have produced results, theoretical results for hypothetical situations. We can clearly use many of those ones. So I don't know if I have a very clear answer for that, but my only thing is that it should depend on a question in hand and the data that you can use for the question.
Thank you. So one of the another question which I guess you have already answered is how do you combine different models in a study? I guess to some extent has already been answered.
Yes, yes. So, so for example, some of these, well, it depends on what is the output for us. So for example, if it is an output is total number of cases in a first wave, or number of cases that one would see on a given day, highest number of cases one would see on a given day, for example, so that you know how many hospital capacity you need, for example. So that is, you can take that one and basically you need to then weight by the property of that model. It cannot be a simple average that one could take for simply the value from each models and then take an average of those numbers. It needs to be weighted by the characteristic captured in those models. What is the mechanism that is being captured there? So yeah, so that's the.
Another question is while using multiple models, how to test to ensure the validity of these models?
Well, again, this is something there's no clear answer to that, and that is the reason there was a huge model from UK by Professor Ferguson, actually very well known in mathematical modeling world, and they predicted millions of cases in UK, and it failed, and it is. Again, it depends on when we're talking about validation. Are we talking about validations for 1 month or 2 months? That is not possible, but 1 week is possible. Now, one thing you can do is, as I shown in my work, we use these burial data, for example, in Indonesia. Yeah, this is the data. This is the data that you can use. That's the correct data. That's you can use for validation. This burial data is an exact number of excess deaths that are happening that you will never going to know from reported deaths, basically. So the burial information in Indonesia, the government was able to provide it, and therefore one can use it for validating your system, whether your model is predicting correct or not. But in general, I think you need some kind of data to say, yeah, it will be, yeah, well, there is some study of sampling study can be done, but that will require time and money. And that, at least for COVID, it is so quick that it is not available right now. Thank you.
So the way I understood is figure out the best source of data and see if your model can mimic that data. And this is how we can understand if our models are behaving accurately or not.
Well, I would not, usually I don't use a word prediction actually. What is model used for understanding what drives the system? There are different mechanisms that we build in the models. And for prediction, as I was giving an example of a climate model, the climate model has been there for a long time, at least 50 years. And there are 50 models that ensemble models that run simultaneously. And then they average out, still they cannot predict beyond 7 days. So, and in spite of the fact that the climate model has the data for very good data, they have stations everywhere, they have satellite images, they have very good climate data. COVID data is very, very weak, for example. So I don't know if I would answer this question precisely.
Thank you. So there's another question. So wherein the statement is like COVID cases are continuously on rise in India. So what factors, in your opinion, you attribute to this, that in spite there's a enforcement of social distancing and other precautionary measures in India?
Yeah, well, there is a very good book by Malcolm Gladwell. The book is called Tipping Point. And I think question is something different, and I'm talking about books, but there is a reason for it. Well, you know, tipping point means, you know, there are many places there are riots happen, for example, but some riots after a few days we don't hear anything about it. Whereas some becomes a big deal. It's quickly spread to the whole region, for example. So why is that happen? Well, tipping point, the phenomena is that basically it is the socioeconomic structure of the population, or that led to the spread of as a wildfire in some cases. Now, if we really want to understand the outbreak in India, my understanding is the social distancing is the best thing. But how do you do it? Well, one thing which has been clearly shown in many places around the world is the use of mask, for example. I mean, we cannot stop people from going from a work, but we can, if there is a mass movement like a riots or like a wildfire, that forces people to think about that we have to use mask. Without mask, what mask is doing is even though you are standing next to the person, the contacts, which are very critical in an infectious disease, infectious means you have to have a contact, is decreasing drastically. So if the mass movement use of mask, not mask, M-A-S-K, I'm talking about, use of mask becomes like a movement in the Indian community, that would be the best thing we can do until we get a very good treatment or until we get a vaccination for this thing. There is, of course, that is one aspect. Another thing that I did not present it today, but if you may allow me one slide to show you, is that okay if I show you one slide?
Please, go ahead.
So I have it in my extra slides, actually. So I think I was short of time, so I cut it in the extra. But there is a paper by, this is published in a Lancet, and it's for HIV. Now, one thing is very important. There is lots of study, modeling study in the literature for other diseases, and from which we can learn very quickly. We don't have to even model new things. Now, this study is talking about modeling universal testing for HIV. Universal testing, right now what happens is a passive testing. Someone is infected, go report him or herself to the hospital clinic, and therefore they get tested and treated. But universal testing is that you go about testing in the population aggressively. You are testing in the mass, basically. And then when you test and find out a person, you actually treat and contact trace that person. That's the idea. So this study talks about, they model this testing and saying in this top right corner, it's an SIR model, simple SIR model. And then there is a testing compartment in the bottom, basically. So every stage of infection that there are 4 stages of infection in HIV has a stages of infection. There is a testing can be done, and then the testing, you can study the impact of the testing. So the result in this study is as follows. This upper left graph, it's saying no interventions, the epidemic is going in some way. If you do only passive treatment, if you don't do any treatment, it's a red graph. If you do a passive treatment, there is a drop in cases. How much drop we can quantify, actually. And if you do universal testing and immediate treatment, it drastically reduces the cases. Now, there is a fundamental principles of physics which says conservation laws. Conservation laws is, if you are getting a significant achievement somewhere, there is somewhere you are seeing some other place you will see drawbacks. And the other place that drawbacks that you see in HIV, if you do universal testing, is basically if you do universal testing and immediate treatment, you will overwhelm the treatment facility, and there will be a lot more cost associated with it, which I don't know whether your city will be ready to do that, something like that. So there's no one answer to that. There's a give and take situation. There's a trade-off of some situations like this one. So that's my answer.
So another question is again related to use of multiple models. So the question is there a prescribed way of deciding weight for each of these models in a multi-model simulation? So
I didn't get the question, actually. Maybe the internet was.
So the question is, when we are using a multi-model simulation,
yes,
and in the end we need to give a conclusion. So
right.
The idea is to average out the outputs from all of the simulation model.
Right.
So how do we decide the weights that we need to give to the outputs obtained from each model?
Yeah, this is actually these questions are very good questions, and I think we should write these questions, and maybe probably a good paper would be very good from a modeling and public health perspective on that. Just an idea. So but you see, there is not a single, it depends on what we are modeling in these things. The weight would go based on those things. And well, there is not one size fit all. I don't have a one answer to that point, but I can say that the weights would let you weights from, for example, what we did was we were using quarantine in all the classes versus quarantine in only clinical classes, for example. And quarantining it for 10 days versus quarantining on an average versus quarantining it for 20 days. What is the impact? So it depends on what is the policy currently getting implemented in that region where we are modeling it. Because if we don't take into account the policies, then our model will be way off. the results basically. So the weights will be decided on the policies and also what we have incorporated in the models basically. So anyway, so this is a short answer, but again, these are very, very good questions to answer, to discuss actually, not to answer, to discuss.
So another question is related to the social distancing aspect. So the question is like, for every epidemic or pandemic, does the model depicts the social distancing as a key aspect? And if so, how then we should recover from an economic crisis? Does any mathematical data or model give such answers?
Yeah, the answer to that is yes, that has been done. My group has done some work on infectious disease and so economic constraint and in some other papers, although I don't have the results right now. But well, when we say this thing, again, one of the things that I was focusing in my work today also was, let me show you some things here. If I could find that very quickly. One thing that is very critical is the definitions that are very important in it. When we say social distancing, what does that mean to us? Social distancing, is it voluntary? It is forced. It is forced only to the clusters. It is forced to the only old age people. What does exactly mean by social distancing? So, and there is, once you define those social distancing definition, then you start to basically give a precise answers to that. But unless we know what is exactly the social distancing we are talking about, we are just shooting in dark right now. Thank you.
So next question is from Adrian from Ecuador. So he's asking, or she's asking, so what influence mobility in Ecuador has in the analysis of COVID outbreak? How can this data be analyzed?
Yeah, well, it's actually a very good question, and I think we are doing a paper on that in Ecuador, and it will be out very soon with my students in Arizona State University. And the goal there is actually, well, again, the definition is important. When we say mobility of what we are talking about? Mobility of interstate transportation, for example, happen in India, migrant labels traveling from state to state. Or we are talking about city movement of the people going to the office. Those things are very, very different that you need to model. And there are consequences from the model very differently. Okay, so from Ecuador, we are modeling mobility between states or between provinces. They call it as a provinces. In India, it is called a state. Well, in Ecuador, there has been a social distancing within the city, but still the buses are working between the cities, between the states. So long distance transportations are going on, and a very short distance within the city, the social distancing are getting implemented. So we are modeling that differences in the mobility and different scales of mobility to see how the outbreak will do. And we are talking about best case and worst case scenario. Best case being there is perfect social isolation. There's no mobility between the states, versus there is a mobility that you leave it similar to what we had before before the COVID outbreak. So mobility could have a drastic impact. And why? Because mobility directly impact contacts, and contacts are directly function of new cases. So mobility could have a significant, just like in India, for example, migrant labels mobility caused a huge problem. Otherwise, think about that. If you close a country down for a month, the infectious period is, let's say, 20 days on an you will not have an infection if it is a strict close down. You will not have an infection at the end of the month. But in India, there's a huge infection still persists. So which is caused by the human migrant of the people or the human mobility in particular. So that's my answer to that.
So next question is from Professor Dilip Mavlankar. Herd immunity. In real world, is 70% or so infection of population is needed, or with less percentage, say 50%, will get to the herd immunity impact?
Yeah. Well, it is a very good question, and I think we are getting a little. It's difficult to answer, and the reason it is difficult is
Can I elaborate, Anuj?
Yes.
Dilip here.
Yeah. Dilip, yes, please.
Yeah. Why I'm asking is in mathematical modeling, many times we assume that there is random interaction between people. But any society, I am told that there's no random interaction. Say upper class interacts with upper class, middle class interacts generally with middle class. So this 70%, which is assumed at random interaction, whether it will in a very structured society, whether at 50% infection, you will get an effect of 70% herd immunity. That's the sense of the question.
That's a excellent, actually. There are, having said that, there are a structured model, by the way. There has been a structured model. Age structure, there's socioeconomic structure. I showed the structure based on, for example, these are all structured model, but the structure is based. We can talk about is, for example, I had another model which was structured on social policies. Let me see if I can find this thing very quickly. Yeah, this one is structured on social policies. Social policies is quarantine. The mixing is different here between Q1, Q2, Q3 versus Q4 versus rest of the classes. So this is, we can find out from using this model what would be the herd immunity. But one thing very critical here is we are assuming here that there is a permanent immunity in the population after one gets infected, which may not be the case, because recently I just read a couple of articles that we may not be having a permanent immunity. We may be having a temporary immunity from that, which is again, I'm not an epidemiological, I'm not a clinical person, and so I cannot. But this is based on recovered, and you can find using such models how structure impact the level of the herd immunity. So people now, our goal here was not to calculate herd immunity, but we can easily calculate what would be the estimates of herd immunity if you structure the population or categorize the population based on mixing of social isolations measures. There are three different social isolation measures here. There's a quarantine, there is an isolation, there is hospitalizations, there's a leakage in the hospitalization as well. So in this model, by the way, so it is, the idea is very different here. So I know I have not answered your question, Dr. Melankar, but I have given some idea about, yes, people have been doing it. And in fact, in Sweden, they did it based on their modeling. They did some modeling before they actually come out with, okay, they will go about going as a herd immunity. But their assumptions, one primary assumption was that you will get a permanent immunity, which may not be the case.
So another question is again from Professor Mavlankar. So based on your expertise in modeling, so any advice to Indian public health authorities for measures that can be for COVID control at this stage?
Yeah, so that's why I was this HIV. I think the best interventions will be test and isolate and contact trace. Delhi government has did it, but then they did it in a very lighter way. But if we follow quick test, active testing, door-to-door active testing. Now, again, it depends on that we should have a rapid detection test, and it should have a very good sensitivity and specificity. Because if we miss some cases, we would start a cluster of an outbreaks. So we should have active testing, and then we should isolate and contact trace and make a clusters as a red zone. The coloring system that they were doing is a very good thing, but it needs to be very strictly followed. And on top of it, the mask usage in general population needs to be there, because no matter how strictly we follow, there will be leakage in the system. There's always a leakage in the system policies, and therefore the mask usage, and there has to be a social movement. For example, in Indian social media, I have been following very much. There has been a mass movement for some Bollywood companies to not to consider them, and so, or not to see those movies. So same thing, we can start the movement of use of mask in everywhere. And of course, we will not be able to have the mask in the restaurant, for example, otherwise how we will eat. But then we need to find, in one European country, they were using a special type of hat, which has tentacles coming out of the hat. So every person entering the restaurant wear that hat, and there are many tentacles coming out, which are 6 feet long tentacles, very soft tentacles. And so any person sit in the restaurant has to wear that hat, and therefore other person has to sit 6 feet away, outside the scope of those tentacles, basically. So I wish I could show you that picture, but right now I don't have that picture. So that's a good idea. These are, now also one thing, very interesting fact that I have learned from smoking literature. In smoking literature, there has been work where, in 90s and in early 2000, there was very high smoking rate in US. And it came down very drastically due to many reasons. But one of the reasons was change in social distancing policies. What that means is, instead of saying, okay, putting a penalty on people who are smokers, just asking them that, okay, you cannot smoke in the building. If you want to smoke, you have to smoke outside the building. Now, what that has done is, that has made people think twice, leave their friend circle, because they are talking with their friends and their social environment, and they don't want to leave to smoke outside the building. So it's an indirect policy that sometimes are very, very effective. And in smoking, it has been very, very, very effective in reducing the smoking rate in the US, for example, and probably elsewhere as well. So indirect measures are very helpful. Thank you.
Thank you.
So another question is, so in the context of a country like India, where there's some people have a doubt of the authenticity of the data itself. So in such a scenario, can we predict future course of a pandemic based on number of cases that are there at present in the country?
Well, cases are a little difficult because there are lots of asymptomatic cases as well, and they are causing the new infection. But this is a fantastic study that was published in Economist. Economist is a news agency, basically. They talked about Indonesia data of burials. So if we start to use the data of burials or of mortality, indirect data, which is not collected by government or reported in the government many times, that data could be used to kind of get a handle on where exactly the outbreak, because there might be a silent spreader in some of the clusters, which we are not getting to know, although the clinical cases are somewhere higher, but those are not a problem. Maybe the places where there are hidden places or silent typhoid Marys, those are the big problems. And these mortality rates would give you some exact pictures of how many died from it, from the cases. Excess mortality, basically. Excess mortality is a standard terminology that people use in epidemiology, by the way.
Yeah. Anu, just for information for everybody, we have used this methodology in chikungunya epidemic in 2006 to show that 4,000 additional deaths happened in Ahmedabad city during 3 months when government was saying that no death has happened. Even WHO was saying no death has happened because of chikungunya.
Sure.
Similarly, in heat wave mortality, the same methodology we have used in Ahmedabad in 2010 to show that 800 additional deaths happened in 1 week during the heat wave, when no certified deaths are very few because of the heat wave. So, and we are trying to get this data from the city, because in the cities of India, the burial and crematorium records are there. And they all get tallied in the municipal birth and death registration office. So theoretically, this information is there. And even newspapers are reporting off and on that these deaths are going up, but somehow the government is not looking at or not releasing this data.
Sure. Well, this is wonderful. Actually, I didn't know about it, and thank you for letting me know. I mean, it is amazing that India is using it. And one thing I want to just add on top of what you said is the modeling can go one step further and can help in kind of giving some uncertainty bonds to it, which would be sometimes helpful. So, like the way I showed just in my slides about underreporting and underassessment, by the way. So there should be, I would suggest that probably more science-based studies and modeling-based studies should be coming now. And India has lots of talents. I have worked with many people in India, and they have so many good people of the modeling and also public health. And I think there are, from PHFI, I have seen many good studies coming out, especially first modeling study that has come out. And I think Sandeep I know Sandeep has worked on those papers. So those studies can do a drastic help to the government and save a lot of money also at the same time when the resources are very limited in India.
So another question is again related to modeling the mobility part of population. So the question goes like, when we talk about mobility between state and within city, so when it comes to cities, then will it be like a short-term visits in both the cases, both city and within city, between state and within city modeling? Or within city, it should be treated like a short-term visit, while mobility between states and cities should be treated like a kind of permanent migration. So how should we treat it like?
Right. So I think here, well, in India, for example, is happening right now. Migrant laborers are moving, and I think that is a permanent migration in some sense for the duration of COVID. I would say it's a permanent migration. But again, mobility is less important than how mobility impact the contacts. That is more important. And why I say that is because, you see, what is happening nowadays is people are, media report has been very much. And so there are some regions where contact rates are getting disturbed because of fear of going out. So that fear part is changing the mobility patterns, which is not the same mobility patterns that we used to have before COVID-19, for example. People, even though they want to go for a work, they are kind of sending messages and they're saying, oh, can I work from home, for example, on internet? So there has been lots of changes in the fear, or there is a behavior change issues that is very important than mobility in general, whether it is long term or short term. in a migrant thing, the change in behavior led to the people, migrants to move. They didn't even think about money. They just wanted to move. And that because of, in that case, it was not fear. In that case, it was because of the food, basically, simply hunger. They wanted to, they're saying they are moving because they have better chances of not dying from a hunger in villages than in cities, for example. And that's why migrants were moving. So those aspects you have to model rather than thinking about homogeneous mobility in the city. And office workers are not going to the offices because they are fear of getting infected, for example. One thing I want to add, actually, in Indian circumstances, I was reading a beautiful story by a writer in BBC. She was Indian. She is an Indian, and she wrote for someone in her family who died from COVID in Gujarat. And one of the things that is very good question from a modeling perspective for India is people are getting infected, but they are not getting, when they call to these hospitals, they are not getting hospital beds. And they are going from one place to other place. And that is causing an extra mortality because some of those patients might have got timely actions. So somehow we need to optimize our resources in how people approach to these hospital or medical facility, which we are not really focusing on, and the modeling world can help in this aspects very much. So thank you.
Maybe the last question, and then we'll close this session. The last question is, again, it relates to the scenario where multiple models are used in a single study. So in such a scenario, for similar input parameters, is it necessary that all the models should provide the similar baseline scenario outputs?
All the models should provide the similar baseline. So, well, the model output would be very different. But again, sometimes, what we do is when we try to predict something, let's say 1 week in advance, then it's not a one number. Basically, we give a confidence bound, a confidence interval. Without confidence interval, it is less significant to give one number. Now, that confidence interval, if it is too wide, then that modeling study may be less helpful in your aggregation process. If the variation through that model, because that means if the variation is quite high, that means what we are saying is that particular model may not be able to capture the data that is coming out and may not be a good model to even use for the given data. So in such circumstances, we may have to either eliminate that model results, or maybe we have to replace it by a different set of models. And then aggregate it. And usually confidence bound plays a very important role in aggregating the results from the models, from the set of model or ensemble of the models.
So with this thing, on behalf of Public Health Foundation of India and IPH Gandhinagar, I'd like to thank you for the wonderful presentation. It was very detailed, very to the point, and very informative presentation. Hopefully, this talk will motivate many other modelers in India to make an attempt to model the situation and throw some of the policy insights that can be taken up. Thank you.
Well, thank you very much for inviting me. It was a pleasure talking to everyone in India, and I miss all of like food and India and all moving out also with this COVID. We are not really moving out. So thank you once again. And I really is very grateful to Professor Dilip Malvankar and Dr. Surabhi Pandey and you too, and Jignesh and everyone else who were really very kind to help me with this talk. Thank you.
Thank you very much for staying up late in the evening, night almost. So maybe next time we will keep it early. So we have maybe after a month or so, we follow up and see how the epidemic evolves in India. Maybe have some more detailed discussion. Thank you very much. Thank you to everybody who attended.
Thank you. Thank you. Thank you. Bye.
Thank you, sir.
Thank you. Yeah.